Welcome to the Many Faces of Addiction and Recovery in St. Joseph County. This webinar is called Hijacked Addiction and Brain Chemistry, and we're sponsored by the Partnership for Drug-Free St. Joe County. We welcome you today. I'm Tara Piano. I'm the membership committee. I am a member of the Partnership for Drug-Free St. Joe County, and I participate in youth initiatives, community awareness, and recovery communities. We welcome you to this first webinar of 3 in this series, and we're happy that you're here. A few housekeeping items. Please place yourself on mute if you are not already. We plan to take up to an hour of your time. We know you are very busy, and we don't want to take up more than the time that you accounted for this session. This is being recorded and will be able to be viewed later on our YouTube page and possibly our web page as soon as we can get that up. If you haven't done already, please put in the chat your name and your organization. And if you need a certificate of participation, please put that in the chat as well. If you have any questions or comments throughout the presentation, please put that in the chat as well. We're going to have someone that is monitoring the chat and will be able to bring those questions to light at the end of the presentation.
Tara,
And
if you could do it in the Q&A, that'd be better.
Sure.
It's better to track it that way. Thank you.
Sure. Right. Yeah, do that. And in the chat, you're going to find the character worksheet. If you have not received that yet, it is in the chat. And if Janet, you can post that again, if that didn't come through the first time, if you can post that, there is a character worksheet if you don't have it already. This worksheet is something that you'll complete on your own. It'll take 2 minutes for you to do. I promise it's not going to take longer than that. This is going to give a way to humanize this presentation. You're going to build your own character that is an addicted person in the community. That may be a substance, that may be a behavior, and it does explain it on that worksheet. This may be someone that you create. This may be someone that you know of throughout your life, whether that is dealing with someone in your personal or professional lives. We are never going to ask you for this information. We're not going to call on you to say, hey, what's your character's name and the issues they're dealing with. We're not going to ask that at all. So this is for your information only. We ask that you bring this worksheet with you for the next 2 sessions after this one. We hope that you attend those sessions with us. You're going to be able to build on that character. And again, we are not going to be asking for that information. The next 2 worksheets will be given in October and November, just like it was for today. So you'll have it for then. And also in the chat later on, there's going to be a link for you to register for the next 2 webinars for October and November. So I hope you join us for those as well. So the point of this webinar is to take a deep dive into addiction for people that you know, people that you work with, people that are in our community, with the effects on the brain, the addicted person, and people around them. And then finally, St. Joe County itself. So right now I'm going to turn it over to Brian Mounts. He is the team leader for youth prevention and Camp Mariposa at Oaklawn. Brian?
Yeah, thanks, Sarah. So one of the things that we really want to kind of take away from this is that oftentimes when we come to webinars or seminar series like this, and we're talking about substance use disorder and we're talking about mental health, we're oftentimes looking at it from like a community-wide approach, or we're looking at it like from statistics and data, as opposed to looking at it from like an individualized process. So we really want you to use that worksheet and kind of as you're going through these 3 webinars, which again, hopefully you will take part in all 3 of them as they build upon each other, you'll be thinking of that individual. And as Tara said, it might be an individual in your life that you know of who is either struggling with a substance use disorder or is in recovery from a substance use disorder. Or it could be just sort of a conglomerate of individuals that you can think of, or just a fictitious character that you're thinking of. And again, it doesn't have to be a specific substance. Oftentimes we might be talking specifically about like an opioid use disorder or an alcohol use disorder, but this can be, a chemical dependence, or it can also be, gambling, it can be porn, it can be whatever. So keep that in mind. What we really want to do here is kind of humanize it. We really want us each to walk away thinking of how we can look at an individual we know who has a substance use disorder, how we might be able to provide our services or our help to get them through the process of active addiction to treatment to long-term recovery. So we really want you to keep that in mind. Think about that individual, think about that person. We want to destigmatize as much as possible. That's something that we're always fighting against is the stigma of addiction. And so when we put a face to it, it helps us to destigmatize that. So as Tara said, throughout the process here, if you have any questions, please put them in the Q&A. If you need a certificate, please go ahead and put that in the chat. We'll be monitoring both of those. And if you have any questions or need anything, please feel free to put that in the chat or reach out to us. So I'll turn it back over to Tara at this point.
Thank you, Brian. So I'm going to introduce our speaker for today. Her name is Dr. Krista Brucker. She is an emergency medicine physician at South Bend Emergency Physicians, as well as an addiction medicine physician at Oaklawn in South Bend. Her research focuses on improving urgent access to mental health and substance use disorder treatment. She is the founding physician of the Oaklawn Addiction Medicine Program and has served as regional medical director for a large telehealth addiction medicine provider. Dr. Brucker completed her emergency medicine residency at Northwestern University Feinberg School of Medicine in Chicago. She is a graduate of Harvard Medical School in Boston and earned her undergraduate degree in biochemistry from DePauw University in Greencastle, Indiana. Born and raised in Minnesota, she currently lives in South Bend. Dr. Brucker, we welcome you, and I hand this off to you.
Thank you so much. It's lovely to meet everyone. I always get a little embarrassed by the introduction, but here we are. I think I need permission to share I got it. Okay. I'm just going to bring my slides up real quick. And I was just looking through the chat to kind of see who is here. I want this to be really useful and helpful. So if you have questions, please put them in. And I'm going to try and be really mindful to save time at the end so that if there are clarifying questions or other things, we can see them. Can everyone see the slides? Oh, no, I can't see them. Okay. Well, if not, someone get on and say no. We can see them. All right. As Tara mentioned, I am an emergency medicine physician by training, and I still work in the Beacon Memorial ER quite a bit. And I also started the MAP program over here at Oaklawn, about 7 or 8 years ago. So I come to this with a real passion for the emergency nature of treating substance use disorders. And one of the ways that I think we can sort of move culture, change culture, make it easier for people to get care is to have a really good understanding of how the disease of addiction affects the brain and impacts the brain, so that we can kind of take it out of this world of like, just try harder, just do better, just stop using drugs, and help people really engage in evidence-based, really highly effective care. So I feel pretty strongly that, I do a lot of training for folks around how to start medications and how to use medications more effectively. But the longer I do it, the more I think that actually changing the culture around addiction and changing the way that the different systems we work for engage with people who use substances is really the key to moving the needle on helping more people get better and live in full and sustained recovery. So the point of the talk today is to try and help ground everyone in the science of what happens to someone's brain when they develop a substance use disorder. We have learned, several lifetimes about how substance use disorders impact the brain and thus behavior in the last 20 years. And so I'm just going to walk through the sort of high level things that we know about substance use disorder in the brain. So at its most basic level, your brain has what we used to call the reptilian brain. Some people call the survival center. It's sort of deep down in the brain, and it is the part of your brain that we share with a lot of animal ancestors, and it was the earliest to develop evolutionarily. And what it's responsible for is survival. So down in the midbrains and the nucleus accumbens are all of the sort of signals in your brain that help you do the things that you have to do to survive. So this is what keeps you breathing. This is what keeps your heart beating. This is what releases chemicals when there's times of stress or danger to make sure that the more developed or more advanced parts of your brain are taking the right behaviors to ensure your organism's survival. The prefrontal cortex, or sort of the top part of the brain, is really responsible for our higher order functioning. So it's responsible for things like executive functioning, planning, making lists, making social cues, so making good decisions in terms of what social situation that you're in. And we know there's like now decades, probably a century of research about how these two parts of the brain interact with each other. And we are just really at the beginning of our understanding of it. But basically, we used to think of that sort of reptilian or midbrain part of the brain as the sort of pleasure sense, the pleasure center. So traditionally, like things that are good for survival have released chemicals, mostly a chemical called dopamine, that basically sends a message to your prefrontal cortex, the more advanced part of your brain, saying like, oh, that was good, you should do more of that. And what happens in the disease of addiction is that sort of reptilian midbrain survival center is hijacked. It's hijacked by all drugs of abuse that we know of to sort of trick it into releasing dopamine when the drug is used, and also to crave it when it's not there. And it's not just like a, oh, I want it craving. It actually, because this is a survival center, your brain actually thinks that like you need this for survival. And so it activates every single mechanism it has to get you to go out and find that drug or that habit again. And we know this from data that are now like 25 plus years old. So we've known this for a long time. And the way that we learned about it is they took these tiny little needles and they put them into the midbrain of rats, and they measured dopamine levels. And they saw that when you keep a mouse or a rat hungry and then you feed it, you get this spike in dopamine. You see it goes from like 100 to 150 there on our scale. So like that tells the mouse in its survival center and in its prefrontal cortex, like, ah, that was good for you. You should do more of that. The same thing happens with reproduction, right? This is something that we must do for the species to continue. And so when you isolate male and female rats and then reintroduced the female, you can see that you get a similar jump in dopamine in that survival center. Okay, this is interpreted by your prefrontal cortex as good or pleasurable or fun so that you do more of that thing that's good for your survival. What happens and why we talk about this as a hijacking of normal chemistry. So what happens in addiction is when you introduce a substance of abuse, in this case, it's methamphetamine, you can see that instead of going from 100 to 200 or 150 to 200, like we saw in the previous slide, you actually go from 100 to 1,000. So when your body sees methamphetamine, you get this release of dopamine in your survival center. That's huge. It's orders of magnitude bigger than when you like eat a really great meal or have a really wonderful sexual encounter. So this is like a huge jump in dopamine, and your prefrontal cortex interprets that as like, oh my gosh, that must have been really good for me. I got to go do that. And what you experience when this happens is the euphoria of drug abuse. As you can see, the same thing happens with all of the known drugs of abuse. And it also happens with a lot of the behavioral habit disorders that we see, like gambling and pornography. So you can see these huge jumps in dopamine in the midbrain. And this is just very straightforward, simple neuroscience from 25 years ago. So we've known for a long time that people aren't just like going out and using drugs because they like them and make them feel good, right? There's brain chemistry here that is habituating people to this use. And it's also, because it's from the survival center, it's also keeping people from making other decisions, because what the survival center tells you is like, this is more important than anything else that's going on. It's more important than that list of to-dos you made. It's more important than social expectations about behavior. It's more important than laws and rules, like what the outside world tells us you can and can't do. It's more important than all of us because this is about survival. And so when people go to get help with a substance use disorder, this is what we're working against, right? This very powerful urge from a very old part of our brain that says, do this or you won't survive. Clinically, for all of those of you who work clinically seeing patients, we see this in the patterns of behavior. So when people first start using drugs, they Are often using from a place of pain, but sometimes they're just using for recreation or fun. We see this especially in our youth, experimentation or risk-taking behavior. And what happens is that they feel good, right? Like they get that big dopamine surge and they're like, holy cow, this is great. The euphoria sets in, like things feel pretty good. And then over time, and it really doesn't take very many uses for a lot of our substances, things, you start to have this withdrawal syndrome because when your brain gets it, it feels good. But when it doesn't have it, it's like, holy cow, goes into hyper aware mode. Like, we got to get this or we're going to die. And so people experience both physical withdrawal and like psychological distress because they're getting all these signals from their midbrain to go do that, go do that, go do that. Unfortunately, what happens over time is that even in using increasing amounts of the drug, people feel less good. They feel less good even when they have the drug, and they feel much worse when they don't have it. And then this is a part of the dependence that develops. Like you're using more, but you're not feeling good. You're not feeling as good as you used to. And then pretty soon, and this is a lot of people that I see in my opiate use disorder clinic, like they're not even enjoying any bit of this anymore. They're literally just using to get out of this pit of physical misery and psychological distress. And so people will come. I hope none of you have ever been in opiate, fentanyl or opiate withdrawal, but if you have, like, it's terrible. It's like the worst flu. Imagine your sickest day, right? Your sickest day when you just could not get out of bed, the worst flu of your life, and then multiply that by like 10 or even 100. Opiate withdrawal is physically very, very painful. And this whole time, your brain is screaming at you, go get it, go get it. You'll feel better. Go get it. If you don't, this terrible thing is going to happen. And so people get trapped in these cycles of physically feeling terrible, having tons of psychological distress. And if we don't meet them down here with effective, compassionate, empathetic treatment, then they really have no option but to go back and use. And so this is how people get stuck in this cycle of their midbrain firing. Their prefrontal cortex can't tamp it down because it's from that survival center. And then our treatment system, being limited and resource constrained as it is, we can't meet people here to help get them out of this spot. And so they really get trapped in a pretty bad cycle. This is not at all to say that people don't get better. People can absolutely get better. People can even get better without treatment. It's just to try and help people understand how hard it is, like how hard it is to just put that thing down. And even if you've never had any personal experience with substance use, all of us know how hard it is to change behavior. Like it is hard to change behavior, even the most benign behaviors. And then when you layer in how the brain has been hijacked, it just gets that much harder. So that's a very simplistic, this sort of midbrain prefrontal cortex, dopamine makes you feel good, so you use drugs and then you can't stop. That's like our very first early understanding. We have developed like whole graduate programs around the neuroscience of addiction. So there is so much that we have learned, and there is so much that we have yet to learn that we don't understand. But I think the most important addition to this sort of compulsivity that we learned about very early on is the connection that that addiction has with memory and trauma. So any of us who have worked in this for any amount of time understand very clearly that there's a very clear link between substance use disorder in families and also in trauma. And so what we're starting to learn is that actually even the sort of midbrain that we talk about is very complicated, and the different parts of the midbrain control different things. And the way that the midbrain sort of talks to each other, talks to the parts of the brain that encode memory and trauma, and then the parts that encode the sort of sympathetic system that's required for survival are very, very complicated. But the point is that there are these complex interactions where someone, even someone who's been in recovery for a very long time, if they have a stimulus or a trigger or a memory that can bring back these floods of emotions and also of neurochemical release that really make it more likely that they'll return to use when presented with a stressful situation. So I really like this sort of conception of how this all works. Like, a lot of people used to think that like people just use drugs because they can't handle life and they want to feel good. Or some people even think like they just don't care about anything and they just want to go feel good. I think anyone who's tried to help someone achieve sustained recovery knows that it's much more complicated than that. But the idea is that this like binge intoxication release period right after you use is actually not the main driver for use. The main driver for use is over here. And I find this to be very true in my clinical practice. Like most people are using not to feel good at all. Most people feel terrible about their use and really want to stop. But the withdrawal, the physical withdrawal and the emotional distress of that negative affect, missing the reward state is what really drives it's what really drives this. And when we have this reward deficit, like we don't have enough dopamine and we have a lot of added stress and anxiety, trauma, memory, all this stuff coming together, then we start having these sort of anticipatory thoughts about use. And then because our prefrontal cortex is less effective than it might be in some other situations, we are not engaging all of the parts of our prefrontal cortex that might help us like play that tape forward, see where that choice is going to lead us, think about like our kids that we have to pick up from school or the probation officer who's going to make me come screen tomorrow. Those are all prefrontal cortex management ideas that are just being completely overwhelmed by all of the stress signals that are coming out of the midbrain. And then here it is, relief. And unfortunately, this is the part where community is so important, because when the relief is so easy to get in a hit of fentanyl, then it has to be just as easy, I guess, to get relief from supportive community, from mutual aid meetings, from effective medications, from a strong therapist. Like we have to be able to meet that need with something besides the drug and something that's easier to get than the drug. And this is one of the big problems that we have in our healthcare system right now, is that it is so freaking hard to access care. So even people who are down here, I know I'm in a stressful state. I know I don't have to believe this thought. I know that if I can just make it through the next 5 minutes, I'll be okay. Like they need somebody to call. They need a door that's open. They need effective medication right then, not in 2 to 4 weeks or 6 to 8 weeks or whenever we as their healthcare providers can get around to it. And so I think that's where we really see the neurochemistry and the community and the healthcare system all coming together to really make it hard on people who are trying to try and get better. This is a great, for anyone who's like, what kind of drug is that? Or what are they talking about when they talk about this? This is a really great website that basically categorizes all the different drugs of abuse. And you can see in here, it tells you if it's an opiate or a depressant or a stimulant. Why it's here in this talk is because every single one of these things and this whole thing they're all different drugs of abuse, and they all trigger the same dopamine release in the midbrain. So they have different, like people act differently when they're taking them, and people become dependent and addicted to them at different rates, but they all have this in common, that they really hijack the midbrain. And a lot of the treatments we have for these different substance use disorders work on the same sort of cycle. So this is just a reminder for kind of what I was just talking about. And, we answer the question a lot about like, why is this so hard, or why can't I just quit using? And I think, there are definitely things that are individual factors that make people either prone to developing a substance use disorder or to struggle getting out of it. We know that about half of your risk of developing a substance use disorder is genetic. So we've learned over the last 15 years that like there are specific variants at the opiate receptor that triple your chance of becoming dependent or addicted to opiates if you're exposed to them. So like that's just in your genetics. That has nothing to do with what was happening in your family or at home or anywhere. There are just some folks who are very susceptible to the disease of addiction. And then there's this whole level of like interpersonal factors. So we see a lot of protective factors in this realm. We know that folks who have even a couple of good influences in an otherwise very chaotic and substance-prone situation, it can be very meaningful. That has nothing to do with the individual person, right? That has to do with the kind of relationships that they have in their families and communities. And then there's this whole level of community beyond that, right? And so we know that folks who grow up in situations where substance use is very common and normalized have much higher rates of developing substance use disorders. We know that it matters a lot what kind of opiates are available for you to abuse or to experiment with when you're a teenager. We know that if if everyone in your high school is snorting Percocet in the bathroom, you are much less likely to understand that as a problem or abnormal or dangerous. And then we also know that if communities have easy and open access to treatment, scientific-based, evidence-based treatment, people have much better outcomes. And then we know that obviously, like, society has a lot to do with what substance use disorders developed, how they're treated, and what kind of treatments are available to folks. In our country, for better or worse, the vast majority of substance use disorder care is provided through our jails and prisons. And so when you, as a society, make that the default place to get treatment and make treatment in the healthcare system hard to access, you change how people access care and how people are perceived in society. So this is all just to say that, like, it's so easy to just look at someone and say, like, my gosh, it's ruining your life. Like, you're not taking care of your kids, you're not going to work, like, what has become of you? When really what we should be stepping back and saying is, like, there are a whole bunch of things that went into this, including a whole bunch of stuff that you have no control over and some stuff that you have control over. Sorry, I can't see the chat. So if there's questions, someone will have to let me know.
Dr. Brucker,
Yeah.
we just asked if you were going to let us share your slides.
Absolutely.
Thank you so much.
Anyone you would like.
Thank you.
Yep. Okay, so I know this talk is not about medications for opiate use disorder, but it's what I do for pretty much most of my life. And I think it's a very nice example of how access to really high quality evidence-based care can really change trajectories for folks. And so here we are again, right? Like, in this up, down, up, down, up, down. If someone intervenes here or here with an effective community-based intervention, or if you intervene down here with effective medications that help people keep people comfortable and calm those horrible cravings, you can have a really meaningful impact. And so in the case of the opiate use disorder, like, we have 3 FDA approved treatments for substance use disorder. And, they are highly, highly effective treatments that really can really change people's lives really pretty quickly. Like, it really, people can get better really, really fast. And even when people have returned to use, they can come back into treatment easily and get better pretty quickly because of these 3 very effective medications. They're slightly different in how they work, and I'm not going to go over that in detail, although I have whole other slide decks where I could talk about that if people are interested. But I think the thing to know is that these treatments, especially methadone and buprenorphine, they are opiates, so they do touch the mu opiate receptor. But instead of giving this horrible up, down, up, down, up, down all the time, they're specially formulated to just give people a steady state to fill those receptors, but not get them high, right? To just fill the receptors and keep them steady all day long. So it keeps them out of these pits of withdrawal and severe craving. And it allows them, I talk to people all the cement foundation. Your recovery, that's what you build on it, right? But you can build the most beautiful thing you want. If the foundation is constantly dipping out from under you, it's really not going to work very well. And so this is where I think, like, we can really work together with our clinical colleagues, providing really wonderful therapy and other social supports to help people build this beautiful recovery. But medication is just a key part of that. And I'm not going to go into this in detail, but when I say that it works, I really mean it works. Like, we reduce people's mortality by 50% in the first week of treatment. There's nothing else in medicine that does that. Like, and I do a lot of work in the ER, and I see a lot of people come in really sick, and there's almost nothing that has a 50% mortality reduction in the first week. We also know that people are just much more comfortable. So you can bring somebody in who's physically miserable, worst flu of their life times 100, and in an hour, we can have them feeling better. We also know this interaction between suicide and opiate use is really complicated and sad. And we know that suicide rates decrease. We know that people, like, even when they still have some intermittent use or they have a period of relapse, like, they're significantly improved social function. So they take care of their kids at higher rates, they're employed at higher rates. they have a lot less interaction with the criminal justice system, both initial interaction and then also, repeat offenses. And people who are in recovery on medications just report a much better quality of life. Like they don't have this constant fear that they're going to slip up and ruin everything again. And then obviously there's a whole nother talk about maternal fetal outcomes, but the long story short is both women and babies do a lot better over the long term when we have them on medications and engaged in treatment. So I think I just want to spend a few minutes and then I'll turn it over for more questions. But, for me, the big question is like, we have this terrible disease, substance use disorder. It's really hard to live with. It has huge impacts on families and communities. And we have these really effective treatments, both medication and therapeutically. And yet we have this huge gap between the people who need help and the people who get it. And so I think when people ask, like, well, why don't people just quit using drugs? Well, because like it's hard to quit using drugs, like we just talked about, and because all of the support that they need is really hard to access. And one of the things that happens when you're in a cycle of active use is everything feels so much harder. And like using drugs feels sometimes like the only option, or sometimes just like the easiest option to get temporary relief from your terrible symptoms. And so when you see it that way, like it makes perfect sense. Like people, are making not good choices, but understandable choices. The other thing I'll say, one of the reasons that it's particularly hard for people with opiate use disorder is the introduction of fentanyl into our drug supply. And so you can see that like people have been using heroin for millennium, right? But we can see that when the overdose death rates really jumped up is when we see the introduction of mostly fentanyl, carfentanil into our drug supply. And so this is what took like a pretty sad situation and made it into a true public health crisis. And it's not just that it's so much more dangerous, fentanyl, than other opiates, but it's also because of something called precipitated withdrawal. And I don't really have time to go into the details of it, just enough to say that like you can't just quit fentanyl today and start Suboxone tomorrow and live happily ever after. You have to tolerate some period of withdrawal to avoid making yourself really, really sick with precipitated withdrawal. And so this keeps a lot of people away from care because they're really afraid of making themselves feel even worse than they already do when they start the medication. The good news is there's lots of great options. I help people every day get off fentanyl and get on to buprenorphine. So there's a lot of fear out there about it, but we have really great ways of helping people get onto medication without a lot of distress. So this is from a project that I ran in Indianapolis when I was there back in 2016. And the point of the slide is really just to say that almost 90% of people wanted a treatment referral. So our idea that like they're just coming to the ER with overdose, they don't care, they don't care about anything, they just want to go out and use drugs. I hear that all the time. They don't want change, they just want to go out and use drugs. When we actually ask people like, hey, can we help you get into treatment today? Almost 90% of people said yes. So that tells us that like, that's not actually the problem. That's easy for us to say because then we don't have to own the fact that we don't actually have enough treatment for them. But that's not actually reality. When people are approached with humility and empathy, like 90% of people want help. 90% of people want help. So this is just a note about how incredibly terrible the treatment landscape is across the country and in Indiana specifically. These dark blue dots are places that offer all three forms of medication-assisted treatment. And then the lighter blue, purple dots are places that offer at least one form of treatment. And you can see over the years, like we have definitely gotten a lot better. This was, I think, 2015 when I started. It was almost impossible. It was almost impossible for people to get into treatment. And obviously, like this has greatly increased, but it's still pretty hard, or it can be pretty hard, I guess, for people to find the kind of treatment that they want when they want it. And this is just like the Indiana specific data. So you can see that, there's a lot more places that are, this is from 2015 when we started, like it was really hard. If you wanted to start someone on methadone, like in any kind of even semi-rural place, good luck. And so you can see that there have been a lot more treatment providers who have joined the landscape since then. And with a good peer recovery coach or a good case manager or care coordinator, like we can get people into treatment pretty much, the same day or within a couple of days. But it takes support because you have to call some places, you have to go through all these phone intakes, and like it's a process. You can't just walk up to a place and say, I want to come today, in most of our communities. And so this is where I think community support, peer support, crisis centers are really important, because the person has to take the first step. They have to say, like, I want help today. But after that, we have to make it so easy. We have to make it easier than going to find their dope man and getting another hit. And like, it's pretty easy to find a dope man, and it's super easy to get him to sell you drugs. So like, we as a care treatment team provider ecosystem have to be really warm, really welcoming, really non-judgmental, and really supportive when people go to do this hard thing, getting off drugs. I probably don't need to tell any of you, like, we just don't have enough people. We don't have enough addiction doctors. We don't have enough addiction NPs. We don't have enough therapists. Like, the system is constrained just by workforce shortages. Again, nothing that anyone who's using drugs did. Like, they didn't make the policy decisions about workforce development. They didn't do any of those things. They didn't decide how much social workers get paid. Those aren't things that the individual who's using drugs owns, but they are things that contribute to making it really hard to get care sometimes. The last thing I'm going to talk about that is really infuriating to me, and is why a lot of people have a really hard time getting out of the cycle of using drugs, and it's treatment interruptions. So today in Indiana, if you go to jail and you're in my clinic and you're stable on Suboxone, you're doing great, you got your kids back and whatever, and now you have a probation violation, or something happens and you get in trouble for some other reason. In every jail, you can go, well, I shouldn't say that. In a lot of jails, you will be taken off your medications, even though you're doing well in our treatment program. When we called every jail in Indiana, what we found was that about 30% of them still just don't allow it. They just say, no matter what, we don't care if you're pregnant, we don't care if you're doing perfectly in treatment, we don't care if Dr. Brucker comes right here with the medicine and hands it to them, they're not getting it, not in our jail. And we know that about half of people who have opiate use disorder are somehow involved with the criminal justice system. This has to change. There is absolutely no reason to be taking stable people in long-term recovery off their medicine when they go to jail. And I know I've worked with enough jails and enough sheriffs to know that it is complicated and it does get diverted, and we have to take that all seriously. But there's absolutely no reason we shouldn't be taking care of people who are we shouldn't be destabilizing people in jail. That's just crazy. Also, for the people who are actively using, there's only 1 or 2 jails in Indiana who will start buprenorphine. This makes absolutely no sense. You have a life-threatening disease. You have a period of confinement where they will go through withdrawal and be ready to start a life-saving medication, and we don't give it to them. And so, again, we as a society have a long way to go in terms of saying, like, do we want this to be a therapeutic space, or are we just going to do as little as we can and let them go and hope for the best? And unfortunately, people who come out of jail not on Suboxone have the absolute highest risk of overdose death of any population we study. They're somewhere between 40 and 129 times more likely to die of an overdose, and they usually die within the first week before their treatment programs can scoop them up and get them back on their medication. So that's on the treatment program. We need to run better treatment programs that can pick people up as soon as they get out of jail and get them back on their meds. Like, all of these little cracks, none of these are the people who are using drugs' fault. These are systems that we have designed and left to be inadequate for way too long. This just for anyone who's needs the data, like, we know that giving people access to medications for opiate use disorder in jail is a good idea, saves lives, and decreases reincarceration within the next 12 months. So we have at Oaklawn started a program where we try and see people urgently, hopefully the same day, maybe the next day, who need Suboxone. And we've learned a lot of really interesting things. About half of the people we've seen since March of 2024 are recently released from jail. So that's a huge number and has been a huge place where we kind of stand in the gap and try and get them connected back to care. 25% are using fentanyl. So we thought this was going to be most people trying to get off fentanyl. But it's actually a minority of what we do. And then just like unconscionably, almost 25% of our folks are just in a care transition. So they went inpatient, they got a prescription, but their outpatient provider can't see them for 2 weeks and they only have 2 days. Or that got sent to the wrong pharmacy and they don't have it and no one will resend it. Like, all of these sort of care transitions that really expose people to a lot of risk. And honestly, like, frustration tolerance is something we work a lot on. I mean, all of us could probably benefit from more frustration tolerance, but it's especially hard for people who are in early recovery. It's just something they often have to work a lot on. And so when they get frustrated, when we put when we erect barriers that have nothing to do with them, unfortunately, there's always this tug back to like, well, there's this easy button over here. And so we have to make it easier for people to stay in care. There's also a whole talk that we could give about shame and stigma, and I'm sure you all know this and feel it, but it's really hard to be in recovery. Everybody's got an opinion about it, especially for people who are on medications. Like they just get a lot of chatter from a lot of people about, they shouldn't be on it, or it's just one drug for another. Are you going to stay on that forever? And so that's another reason that it's really hard for people to stay in treatment when they have their church or their NA group or their friends saying like, hey man, you got to get off that. You got to get off that stuff. So I think the best thing that we can all do, although I'm sure we're all working in different ways to try and address the gaps in care, I really think, like I said at the beginning, that we have to just change how we think about people who use drugs and the disease of addiction. And I think the best way to do, I stole this from a harm reduction coalition that I love, but for me, the best way to do this is to try and keep going back to my root perceptions about folks. Like we have to believe that they're capable and trustworthy and wonderful people, not just when they're sober, but when they're using drugs. And I know there's a lot of negative behaviors that come along with the disease of addiction, but there's also a lot of wonderful stuff. Like people really try hard to do the right thing. They take care of each other. They have lots of interests that have nothing to do with their drug use. And if we believe that, then we can, if we have those core perceptions, then we can build beliefs that like people are capable and that they can tell the truth and that they care about their communities and want a better life for themselves and their children, just like all of us do. And that will lead us to actions that feel really good to people who are using drugs. If you want to start on the other side and believe that people are lazy or not trustworthy, you're going to grow actions that people who are using drugs can feel as stigmatizing and negative, and you're going to further alienate them from the care they most desperately need. So I think that's where I was going to stop today. Oh, I have one last quote, which is from one of my mentors in San Francisco. And he talks about building an ecosystem of survival, which helps focus us on the fact that like, if we don't do this right, young people will die. And the whole idea is at every interaction, at every touch point, we just help move them away from the harmful things and towards wellness. And it doesn't matter what the intervention is. It doesn't matter how many times they failed. If at every touch, we're just trying to move them away from harm and move them towards wellness, over time, like they will gradually move into remission and recovery from their substance use disorder. All right, I'm going to stop there. Oh, I put my name and cell phone number there. If anyone wants to reach out and be in contact, I'm happy to try and help however I can build this ecosystem of recovery in Indiana.
Thank you so much, Dr. Brucker. Very informative, especially from someone in Indiana, and then even especially someone in our own community. So thank you so much. We're going to get to questions in a second. I see we have at least one.
Yeah.
But I would like to ask that participants take a look at your character worksheet at this point and take note. I'm not going to ask you to do this right now, but I would like you, after we're done here, to just kind of take note of the things that Dr. Brucker mentioned and how it applies to your character that you created. Is your character's brain functioning how you thought it would be or should be? Or how are the decisions being made and not made? How is their life affected? Just take a moment to ponder that and take a look at your character. And then again, hold on to these worksheets until October, and then November. So let's move on into the chat, I believe, with questions, answers, certificate. Yes, you may. And then I believe we have a question in the chat. Are there ongoing discussions, and Dr. Brucker, I believe this is for you, are there ongoing discussions or initiatives focused on expanding inpatient treatment facilities and supportive housing for individuals with a mental health diagnosis who also have co-occurring substance disorder?
Yeah, I'm sure there are. What I can say is that the landscape is much better than it was 10 years ago. So I know it can feel really negative when I talk about all the ways that system isn't functioning, but even here in St. Joe County, like we have a relatively new inpatient treatment center over in Mishawaka. And we have, I mean, from our experience at our crisis center is that if you come in and you say, I want inpatient treatment, as long as your hip is active, which is a big if coming here in January, like we can we can walk you through the process of getting somewhere either the same day or the next day, almost all of the time. You might not always be able to go exactly where you want to go. You might have to go a little farther afield, like Fort Wayne or Indianapolis. But I do feel like we do have the inpatient capacity to scoop people up. Now, sometimes the process is still too complicated, so people get frustrated and they leave before we can get them there. Sober living is a little bit more complicated. We definitely still have challenges with sober living, and we definitely have challenges with the sober livings allowing people to be on these life-saving medications.
Thank you. Brian, I do not see hands, but if you do, will you please call in people?
Oops,
You're muted.
Yeah, let me take a look around here and see.
And
I don't see any. Janet, do you see any? I'm unable to.
I don't see any, but I
All
am
right.
going to I'm going to at least put the flyer in for the next two sessions as well. Or Brian just did that.
Okay.
Or he's doing it, I think. But I can.
All right. So you see the links in the chat. You see the worksheet. Please bring that back in October. And please feel free to register for October and November. Dr. Brucker, we thank you so much for your time today. I know you're very busy, so I appreciate it so much.
And I will
And
send you the slides. I'll send you all the slides and you can feel free to share them with folks, however you can get them to them.
that
That
would
would
be
be
wonderful. I
great.
appreciate it.
All right,
Thank you.
wonderful. Take care, everyone. Have a good day.
All right. Everyone have a great day. Thank you.